Hi, this is Lakireddy with Fits on the Go. I'm about to interview Dr. David Holmes, who's here to talk about his one-year results from the TVT Registry.
The registry was formed with the aim of developing the denominator for all TAVR patients in the United States. In the past, we have had subsets for post-market surveillance or post-market approval. So you had then a numerator and you had then a small denominator.
I see.
This was an intent to capture every single patient in the United States that then is undergoing TAVR, so we could look at then outcomes. And as part of this late-breaking clinical trial, we then said it would be nice to merge the data from the TVT registry of the denominator with administrative claims data at 1 year, provided by the federal government.
Okay. How many centers did you were able to recruit from?
230 patients. 230 centers.
Okay.
That's virtually all of the centers in the United States that do TAVR.
Oh, excellent. And how many patients do you
There
have?
were almost 6,000 patients, so 5,988 patients, in whom we then were able to link TVT data with CMS administrative claims data for the first time in this experience.
Excellent.
So the things that we looked at were, number one, how did things go from the patient standpoint? This data had been published earlier that was in hospital and 30-day outcomes. But the focus of this paper was to say what is 1 year outcome in these linked patients.
I see.
We found at 1 year that, number one, this group of patients who were elderly and had all sorts of comorbid conditions, 26% mortality at 1 year. 3% incidence of stroke at 1 year, and then the total of 29% or 28% death or stroke. Of interest, more than half of the patients were discharged alive and had not required a repeat hospitalization at 6 months. So in terms of quality of life, that winds up being a pretty important thing in terms of being able to avoid repeat hospitalization.
I see.
We then looked at specific factors that might be associated with 1 year mortality or 1 year stroke. So we looked at the typical sort of factors, which would be age and gender, chronic obstructive airways disease, end-stage renal disease, all the things that you would imagine.
Right.
We found some interesting things that were not anticipated. Number one, we did find that there was an age-related increase in mortality at 1 year. Not surprising. Ranged from 20 to 30%, depending upon whether you were 75 or 95. Number two, when you looked at the age variability and its effect on stroke, there wasn't any. So stroke rates varied, but indeed, they weren't dependent upon the age.
I see.
The next piece of information was to look at gender. When you looked at gender effect on mortality, men died more frequently, statistically significantly more frequently. In terms of stroke, it was just the flip. More women had stroke than did men. Women made up about 50% of the population. When we looked at end-stage renal disease, when we looked at chronic obstructive airways disease, with all of those, the more severe the baseline abnormality, the worse they did. That's not terribly unsurprising in terms of mortality, but it didn't affect stroke. So at the very end of the day, those variables that are associated with increased mortality at 1 year are male gender, age, end-stage renal disease, severe chronic obstructive airways disease, and predicted STS score. But the only factor associated with increased stroke rates using multivariable modeling was female gender. So it's pretty interesting. The thrust of this then is to look at associations and then use these associations to develop then risk prediction models to better optimize patient selection. So that's the nuts and bolts.
Nuts and bolts.